Okay, record.
It's being recorded already.
Yes.
Yeah, yeah.
Okay. Good evening, everyone. Okay, you can stop sharing your slide first.
Okay. Right.
Hi, good evening,
Hi.
everyone. Welcome back to another session of our Wednesday webinar with Beating Hearts. And I'm Dr. Betty Tay, the founder of Beating Hearts. And tomorrow is my birthday. Okay, I have here with me my colleague from Sunway Medical Centre, Dr. Wong. She is actually a breast surgeon, but she's so sick of breast surgery. Today, she's going to talk about endocrine surgery. So interestingly, breast surgeons are most are also endocrine surgeons, right?
Yeah, yeah.
Do you mind telling us a little bit more about that?
Somehow our fellowship training system is divided into two. So it's either doing a breast and endocrine surgery together, following the British UK style. And then there's another group trained by the just breast surgery and reconstructive surgery alone. So that's how it come about because endocrine alone is kind of like a small subset, and the cases are usually quite rare. So they just lump it together with breast. So that's how, yeah.
Okay, so today we're going to talk about endocrine surgery and not breast. So
Yeah.
without further ado, I think we won't wait for Fiona. We will just go ahead.
Sure. So first of all, I'd like to thank Betty for inviting me to give this talk. She's
I
been
have to point
pestering me
a
for
gun.
months.
I have to point a gun at her head to get this talk going.
Right. But I'm very grateful that you asked me to present. So thank you very much.
Yeah, because
Um,
endocrine
yeah.
surgery, not many people know about it, right? Okay.
Yes. So I don't know whether you all remember, but when I was in medical school, endocrine is the most, to me, is the most difficult and boring topic ever. It's like, what is parathyroid? What is primary? What is secondary?
Oh,
Even I
yes, yes.
keep forgetting. It's so complicated. And I actually in the end I kind of like surprised how I ended up doing endocrine surgery. Yeah. I noticed in your advert in the Facebook that I'll be talking about all the endocrine surgeries, thyroid and adrenal. But I think if I do that, I'm gonna take up the whole night. I think, yeah. So I decided to just concentrate on parathyroid, which is something that is actually quite common, more common than we think. It's just that we think that is quite complicated. So I would like to share something about that. Yeah. So is it okay if I share my screen? Let me try and share my screen. So how did I get back just now?
Okay, at the bottom
Oh
there.
my god! Yeah.
Don't cry.
There's a button, but it's like so complicated here in my
At
head.
the bottom there is a
Yeah.
share button, yeah? Okay, let me see.
Yeah.
Yeah, it's multiple sharers, so still
Yeah.
you're fine.
Yeah. So sorry. Let me try and look
Okay.
for it. The documents. Okay. So can you see something?
Yeah, that's right.
Yeah. Okay. So yeah. So today I would like to concentrate just about primary hyperparathyroidism. So like I mentioned just now, most people think that this condition is very rare. It only presents later stages in the disease, but actually it's more common than we actually think. So that's what I would like to share about tonight. Basically, just a little bit something about the parathyroid glands. So most of us actually has 4 parathyroid glands, okay, up to 85% of the overall world population, okay. So, and these 4 glands typically lies behind the thyroid gland in the neck, anterior neck. So, but we do have some people who actually has more than 4 glands. I've seen people up to 6. So, and it's also very common for each of these person to have parathyroid gland have various location in the neck or mediastinum. It's not necessarily just located behind the thyroid gland. Normal parathyroid gland, each of them is very, very tiny. It's like a bean shape, like pigeon yellow color, and it weighs only about 20 to 40 grams. So it's about like 5 millimeter size only. Um, so just a little bit something. So this is how it looks like behind the neck. Behind the neck on the posterior view. So it's just 2 on the superior part on each side of the thyroid gland and 2 below on the thyroid gland. So like I mentioned just now about all the variable positions in the neck, it may not necessarily just lie directly behind the thyroid gland. Sometimes it can be on the carotid sheath. Sometimes it can be low down in the mediastinum or in the thymus itself. So what does parathyroid gland do? So parathyroid gland is actually regulates our calcium, our serum calcium via secreting the parathyroid hormone. So the parathyroid hormone actually has its action on 3 target organs, which is the bone, kidney, and the gut. So what it does is it stimulates these 3 organs to produce more serum calcium in the blood. So this hormone actually has a very short half-life. It's only 2 to 4 minutes. And the secretion of this parathyroid hormone is mainly controlled by our blood ionized calcium level by the calcium sensing receptors. And how the rate of the secretion of the parathyroid hormone is also controlled by our catecholamine levels and the magnesium level. So what exactly is primary hyperparathyroidism? So primary hyperparathyroidism is actually typically characterized by hypercalcemia and elevated parathyroid hormones. So the commonest cause of this primary hyperparathyroidism is actually parathyroid adenoma, which is out of the 4, one of the parathyroid gland has an abnormal tumor that secrete excessive parathyroid hormone. But do bear in mind, adenomas can also occur more than one parathyroid gland. And we do have other not so common causes of primary hyperparathyroidism, like multi-gland hyperplasia, in whereby all of the 4 parathyroid gland swells up and produces excessive parathyroid hormone. Parathyroid carcinoma, some MEN syndrome, multiple endocrine neoplasia. These are familiar syndromes, hyperparathyroid jaw tumor syndrome, and family isolated primary hyperparathyroidism. So a little bit something about this familiar and the familiar condition. Usually they are more common in the pediatric population. So if let's say if we encounter some children who has abnormal high calcium and abnormal elevated parathyroid hormone, we need to investigate for any familiar condition that may causes this. So, a little bit something about hypercalcemia. I'm sure you all have heard of all the typical hypercalcemia symptoms, which is stones, bones, abdominal groans, uh, the the uh, the symptoms. So these are typical manifestations. So kidney stones are one, severe muscle weakness is another one, bone fractures, and some kidney stones, okay, and some polyuria or hypercalciuria. But do bear in mind, we do have many patients who has these atypical manifestations of hypercalcemia. So there's a whole wide range of symptoms under this classification. So I have to just divide it into mainly 5, which is neuropsychiatric, neuromuscular, cardiovascular, skeletal, and gastrointestinal. So this thing about atypical manifestation is like, for example, if neuropsychiatric patient can come with very subtle symptom, like they are very sad for no reason, depression, they cannot concentrate, they tend to have lose memory easily, but it's not specifically characterized rather long term or short term. Okay, frequent complaints of illness like headaches or lethargy with no apparent pathological causes. Many of them complain of some muscle weakness. They complain that they get tired easily. So a lot of them, maybe they would be mistakenly diagnosed as having a chronic fatigue syndrome. Okay. Cardiovascular manifestation are such as hypertension, bradycardia, shortened QT interval on the ECG, and left ventricular hypertrophy. So in regards to skeletal and rheumatic symptom, like I mentioned just now, many of them will come with non-specific bone and joint pain. They'll be saying that, oh, I'm having some knee pain. Suddenly they will saying that I'm having some shoulder pain. I'm having some back pain for no reason. So then you need to be aware of this condition that hypercalcemia can cause all these kind of symptoms, and also gastrointestinal. So many patients come to the clinic saying that they have some abdominal gastric symptom, nausea, anorexia, some weight, abdominal pain, or they've been diagnosed as a peptic ulcer disease, or they have acute pancreatitis. So you need to be aware that hypercalcemia can actually causes these conditions as well. So, but looking back, in is it really really rare to patients to have hypercalcemia? So I just want to highlight this paper that is published by Professor Mia a long time ago in 1978, and they reported that they only found from 1978 to 1989 they only have 12 cases of hypercalcemia, and of all these 12 cases, a lot of them all have advanced symptoms already. So, but then again, this is way back like 40 years ago, right? So I give you some recent more papers by this group of doctors from US who actually conducted incidence and prevalence of primary hyperparathyroidism in the US. So this is done sometime in 2012. Okay, so then they mentioned that during 2000, the year of 2002, there was a spike of cases of hypercalcemia. One specific thing that I would like to mention about this year is that they started having a mass screening for hypercalcemia for all of their population. So they found there's a lot of patients started having all these incidental finding of hypercalcemia. And from that point onwards, we can see that the incidence is just slowly rising. Maybe some of you will say that, oh, this is in US, can't be happening here in Asia. So I present another similar papers by China. Okay, so they also uh, published a paper talking about the incidence of hyperparathyroidism in China. Okay, and they also mentioned that the number of hypercalcemia is actually increasing starting from year of 2014, and that year also is the year that where they started doing mass screening of calcium for their population. So the same thing that I can mention about this paper done in this group of doctors in India. Okay, they also review of their incidence of hyperparathyroidism in India, and they find that actually those with asymptomatic, with no symptom whatsoever, is actually made up most of the cases of primary hyperparathyroidism in their country. So so what I would like to highlight is that in the past, from 1930s, majority of the patients who presented to the endocrine clinic with hypercalcemia are those with symptoms. But when you do mass screening and those asymptomatic one, this actually number shoots up, especially in the more recent 2000s, because when people are more aware and the government or the medical side do screening, so I mean, this number will actually go higher up. So, like I mentioned just now, the incidence of primary hyperparathyroidism is actually higher and more common than you think. So, overall, the incidence is actually increasing because increasing prevalence of the asymptomatic cases. So let's just say if we do a routine biochemical screening, then this number will actually go higher. So basically, many you all probably will ask how to diagnose and how to screen. It's actually very easy. Just take blood, check the serum calcium, and check the parathyroid hormone levels. So if you see rise in these two levels, then it's already good enough to diagnose a primary hyperparathyroidism, and you can actually refer to us or endocrine specialists because other causes of hypercalcemia in a non-hyperparathyroidism cases, the parathyroid hormone levels they actually go down because it's being suppressed. And we actually have this one typical condition we call normal calcemic hyperparathyroidism, whereby the calcium level is actually normal, but then we actually notice that the parathyroid hormone is actually high. Okay, and we already excluded secondary hyperparathyroidism. So who exactly to screen and target? You can't be like taking everybody's blood and check their calcium and parathyroid hormone level. So typically, those who have this primary hyperparathyroidism, female would be more, actually 3 to 1, and they commonly falls in the middle age group from 40 to 60, and they have some osteoporosis. When you do some BMD study, then any abnormality. Okay, if you check there's some hypercalciuria in the urine, any patients with renal and urinary stone or any symptomatic patient that make you probably suspect that it's a hypercalcemia. Okay, so what let's just say what are the other investigation to check when the patient is being diagnosed or suspected of having primary hyperparathyroidism? Usually, ideally, we would still want to exclude other causes of hypercalcemia, such as end-stage renal failure or any familial syndromes. So renal profile is important. Checking the ALP to see the skeletal mass. Okay, vitamin D levels, because actually our population, we do have a good number. I mean, we majority of us actually have low vitamin D levels, and vitamin D levels actually would tend to stimulate the parathyroid gland and increase more parathyroid hormone. So once primary hyperparathyroidism has been confirmed and diagnosed, then we will proceed with the localization study, whereby we will order a neck ultrasound, SESTA maybe scan, or SPECT CT, maybe MRI as well. So basically, there are many causes of primary hyperparathyroidism, which just now I mentioned a single adenoma in one of the parathyroid gland is the commonest cause. Uh, uh, but we do sometimes get double adenoma or multiple gland hyperplasia. And one thing to note is that actually this multiple gland hyperplasia, the incidence is actually higher than we expect. This actually make up to 15% of all the cases of primary hyperparathyroidism. So this is something that us surgeons need to take into consideration when we do surgeries on patients with hyperparathyroidism. Other rarer causes are, like I mentioned just now, parathyroid carcinoma and the genetic disorder. So these are just examples of localization study. The commonest mode of imaging that we usually request is sestamipy scan and also an ultrasound neck. So usually we prefer to have full imaging study to confirm a single parathyroid adenoma before we embark on the surgery, because sometimes the specificity of the one single imaging alone is not high enough. So maybe many of you would ask, since most of the patient is asymptomatic, do they really need surgery? Because patients will probably ask also, I don't have symptom, why do I need surgery for this? I can show you many papers that actually publish specifying the advantages of doing the surgery. It's actually more for long-term benefit. So it reduces the incidence of osteoporosis by increasing the skeletal microstructure and bone strength. it reduces the risk of getting urinary stones. Okay, and also many patients actually they do report that they feel better after the surgery. So it actually improves the health related quality of life. They don't feel so down anymore or having some muscle aches anymore. So this is actually one of the guidelines that we follow when we choose patient for surgery in asymptomatic patients with primary hyperparathyroidism. So these are the criteria that usually mandates that okay, we
Sorry,
God.
don't know who.
okay.
Can you please
So
silence your what, please? Okay.
sorry.
No, somebody
Okay.
didn't silent, didn't mute.
Okay.
Okay.
Okay. So can I continue?
Yeah, please do. Sorry. Sometimes it just happens.
Right. I'm finishing actually.
So soon? Okay.
Not yet. Just a little bit more lah. Okay, so next I would like to share about how we do the parathyroid surgery. So the standard incision will be the neck incision, like doing a thyroidectomy surgery. Actually, nowadays we have many approach of doing a parathyroid surgery. So unilateral neck exploration, we just make a big incision over the neck and we explore both sides of the thyroid. And unilateral neck exploration. Most recently would be this minimally invasive and focused parathyroidectomy, whereby we make a tiny incision over the anterior neck and we just remove the intended parathyroid adenoma that is already identified on the ultrasound and a sestami B. And the latest one would, I'm sure you all would heard of the endoscopic transoral parathyroidectomy, whereby we do it endoscopically. Okay, so
Sorry, when you do the minimal, go
yeah.
back. Yeah. Oh, okay. You're going to explain this. Okay, go on. Sorry.
Okay. So let me start with this minimally invasive surgery. It means that we just make a tiny incision over the neck, directly over the adenoma that is already identified on the ultrasound. Okay, so usually incision is actually very small, like 1 centimeter, 2 centimeter only. But we can only then we just dissect in, look for the adenoma and take it out. So this can only be done if there's two imaging modality that actually confirm the location of the parathyroid adenoma. So, but in order to make sure that the surgery is successful, that we have actually removed the correct parathyroid adenoma, it need to be accompanied by intraoperative parathyroid hormone monitoring. So unfortunately in Malaysia, I don't know any hospital that has this service because we need a special machine and anesthetist needs to help us draw the blood out and measure the parathyroid hormone immediately after drawing. So we have intervals after removing the adenoma at 5 minutes, 10 minutes, 1 hour, 30 minutes and 1 hour. So which is why it's not very popular here in Malaysia because we don't have that machine, the intraoperative parathyroid hormone. Okay, so so what I usually do here, I mean, is the unilateral neck exploration, whereby the incision is longer than a minimally invasive, but it's still shorter than the standard thyroidectomy surgery. So because if two studies have already confirmed that the location of the parathyroid adenoma is on right side or left side, I only need to examine the other parathyroid gland and confirm that there's only one adenoma that is the source of the hyperparathyroidism. So this is because I don't have the service of intraoperative parathyroid hormone. Okay, so in the past, when we don't have this a lot of imaging modality, the gold standard surgery is doing a standard neck incision like a thyroidectomy, and we explore all four. We open up and we flip in anteriorly the thyroid, and we examine all the 4 parathyroid gland before we remove the adenoma. So this is the gold standard lah.
Sorry,
But
chop,
yeah.
As it is, the parathyroid gland is very small.
Yes.
The
So
adenoma in itself cannot be very big, right?
yes, that's the thing. So that's our difficulty in looking for the adenoma. So it's it's not as easy as doing a minimally, okay, it's there and cut directly above, and you'll be able to take it out. So that's why surgery for parathyroid adenoma is very tricky. So whereby that's why they have all these tips and tricks of teaching us how to remove the glands. So we need to examine all of the 4 glands before we decide to remove the most abnormal one.
Wow, that's a bit risky
Mm.
without
Yeah.
imaging modality.
Yes. So for me, because I don't have the intraoperative parathyroid monitoring,
Yeah,
so what I do is, if this the SESA maybe scan and the ultrasound confirm that the gland is probably on the right side, I just explore the right side. Just make sure that the other gland is normal before I remove the adenoma.
I see. Okay.
Mm. Okay, so let me talk about the endoscopic part. So right now, this is one of the
Oh,
recent and quite popular endoscopic methods of doing a parathyroid surgery. So we call this endoscopic transoral thyroidectomy. So we put the pods into the mouth, like you see in the photo there. Okay, so we insufflate the space with gas, and then we do a standard thyroid. We flip the thyroid anteriorly, and then we look for the parathyroid gland. So why this is popular? Because it avoids any neck incision at all. So, and also the one of the advantage of this approach is that it also allows bilateral neck aspiration. But personally, I don't do, because there's so many risks associated with this endoscopic procedure, like gas embolism, which can cause cardiac asystole, okay, some mental nerve injury, and I have seen photos that the pot actually punctured through the mouth and there's a big hole over the mouth. So
oh my
so
God.
I'm a bit like yeah. So actually I'm a bit like hesitant to do lah. So yeah. So let's just see if I have we do have patients who actually not fit for surgery, or we think that they may not benefit for parathyroid surgery. So we do have guidelines to follow. Let's for medical monitoring, uh uh if they are not fit or not suitable for the parathyroid surgery. So this is the guideline that we follow. So this is my last slide. Okay, so just in summary, the incidence of primary hyperparathyroidism is actually going higher and higher, but this is higher because there's a lot of patients with ACE who are asymptomatic and they just accidentally found it on the blood test. Okay, but you need to be aware that those with mild hypercalcemia, they can present in myriad of complaints and weight symptoms and signs. So doing these 2 simple serum calcium and parathyroid hormone level, it would be very helpful to detect this kind of patient. So of course, people need to be aware and be vigilant in detecting this kind of patients. And I would like to highlight that doing surgery does provide long-term benefits. But of course, we do have guidelines in selecting which patient that is indicated for surgery or not. So that is the last of my slide. Thank you for listening. So, any question?
Yeah. Any
Yeah,
questions? I
yeah,
don't see any from what, but I want to ask,
yeah,
are the symptoms that you say, those vague symptoms from psychiatric symptoms to other
yeah,
symptoms, are they related to the calcium level?
yeah. Because hypocalcemia somehow affects because uh s- ionized calcium actually does affect the neurological transmission, like
I see.
our sodiums and potassium. So in a way, it does affect. So that's the thing. So many of them, they would have some depressed for no reason. Probably it's due to the hypercalcemia.
Okay. Then the
Yeah.
other thing is, there are some people who have no hypercalcemia.
Mm.
For these people, how do we find out? We don't
So so so
PTH
you,
level, what?
yeah, correct. So only in I would say only in the US and probably some of Japan and Korea, they check the 2 levels together, the parathyroid hormone and the calcium. Like I mentioned just now, parathyroid hormone can be raised, but normal calcium. So actually, this group of patients, they are actually a special group of patients whereby surgery might not be helpful for them early in the stage. So actually, so at the end of the day, there's no need to actually examine for the parathyroid hormone. So once you check there's a high calcium level in the blood, that itself is already enough to refer the patient to an endocrinologist or endocrine surgeon.
Is it very expensive, parathyroid hormone measurement?
Yeah.
Oh,
In Sunway, I think it costs about 120 ringgit.
120?
Yeah.
Oh, not so expensive lah.
Okay
Not
lah.
like 1,000 lah. Not like 1,000 lah.
No. It's only 100 plus. So as compared to serum calcium is only like 50 ringgit. So there's a big difference there, like double.
Oh, I see. But it's not like really
Yes.
actually,
It doesn't go beyond
the GPs
1,000.
can do it quite
Can.
easily.
Yeah. Can.
Yeah.
GP.
Any
Yeah.
GP can do it quite easily.
Yeah.
Okay.
And I'm sure most of the lab does have this test, the parathyroid hormone level.
Okay, this hypercalcemia, you can see hypercalcemia in stage when there's secondaries to the bones. Is the hypercalcemia level very high, substantially high, like 4 or 3.6?
Usually those that severe high enough, they already have severe symptom that would require them to be admitted. So this would be probably like in the range of like 3.0 to 3.5. Yeah. So yeah.
Oh, so those but it can be just on the upper limit, I mean,
Yeah.
higher?
Yes.
Okay, so it is important to keep in mind when the calcium level is high. Because most times I will just like,
it's nothing. Yeah. Maybe it will come down. Right.
Yeah.
Yeah.
Because you see now patients are really like wellness and health screening is like part and parcel of the yearly routine for many people.
Yeah.
And so sometimes you do see slightly high calcium level. It is not remarkably high. It's like 2.343, like slightly high.
Yes.
And then, of course, Betty Tay has already forgotten the formula, how to correct it to the albumin.
But most lab
You correct it to your
actually
albumin. How do you
provide the value for you, the corrected calcium level.
Yeah,
So
yes. Now they sometimes do provide a corrected calcium level for us, but sometimes don't. And when I was a houseman, it was like, how do I correct it? But now I'm like, how do I correct it? I know there's Google, but then, so sometimes when it's slightly elevated, I'm like, okay, let's just repeat it the next few months. But then, of course, patients sometimes may not come back.
Yes, correct.
Yes.
Yeah.
So
So usually those with mildly elevated symptoms, if you ask them more, they would give you some symptoms actually, like, do you have pain? Then they will like, oh yeah, I do have some vague back pain, this and that. That will probably prompt you to like investigate more. So they're not really asymptomatic. They do have symptoms, but it's very, very vague and atypical.
Yeah, the vagueness and the atypical.
Yeah.
We will say psycho.
Yeah.
For sure. Oh, I think you are under a lot of stress.
Yes.
Because if you mention the list of the symptoms that one has, so now please everyone.
Yeah.
Even a slightly high calcium level, think of primary hyperparathyroidism, and PTH is not that expensive to order, and anyone can order. 2 is don't dismiss all patients with vague symptoms. And the list is exhaustive. It's like going on forever, your list. Okay, Dr. Ong asked, how is hypercalcemia? How does hypercalcemia cause osteoporosis?
Because parathyroid hormone works by it's increased when it senses that our body calcium is low. So when we have when we have too low calcium, the body releases the parathyroid hormone, and this parathyroid hormone stimulates the bone to release the calcium ion. So that's how we get osteoporosis, because it actually like eroding the bone by taking the calcium from the bone. So that's why osteoporosis is one of the major symptoms. Yeah.
So anyone else? And then another thing is taking calcium supplement does not help osteoporosis, okay? To everyone.
Yes, it doesn't help.
What is
No.
the commonest symptom of hypercalcemia?
I would say muscle weakness. So some like so severe that we do have many who are actually admitted because of muscle weakness, and then when they check the blood, they say, okay, the calcium is very high. Then that's how the endocrine physician comes in. Yeah, so muscle weakness is the commonest.
Okay. I
Yeah.
thought you were going to cover all endocrine surgery except breast. And you talk about parathyroid only. So now we have
Yeah.
to invite you to speak about thyroid.
Oh dear.
Thyroid. What else is there? Pituitary? No, pituitary.
Adrenal.
Adrenal.
Yeah.
Adrenal. I see. Adrenal.
Yeah.
So, okay, when it comes to hyperplasia, means everyone is active, reactive, or active. I'm not sure.
Sorry, what were you
For
saying?
example, you said that one of the commonest, 15% of them have hyperplasia. Is it hyperplasia?
Multi-gland hyperplasia, whereby all the 4 glands are secreting excessive parathyroid hormone levels.
So how do you treat that?
This one is quite tricky. So this one usually I would need to discuss with the endocrinologist, the physician, where do I need to remove all the 4 and leave half behind, or I take out all 4 and transplant a little bit behind. So yeah, so
Why don't you,
means that I chop some tissues of the parathyroid gland and put it back into the neck muscle.
why don't you just leave one then?
Because that one alone is producing a lot of parathyroid hormone, then the recurrence is
What
still.
if you take out all and then there's one?
So I cannot leave one behind. So what we do is we chop a small portion of the gland, and then we put it back into the neck.
I see. And it still works.
It still works.
Okay, if you take
Parathyroid gland is amazing one. Yeah, you chop it off, then you put it in a muscle. It's still alive and it's still producing hormones.
Oh.
Yeah.
But oh, that's interesting. And
Yeah.
it's already like one small bean.
Yeah.
So when you just take a little bit and reposition it,
into the neck, and it's still alive, and it can still produce parathyroid hormone normal.
Okay, let's say you have no parathyroid hormone at all.
And then we would be in trouble, because the patient would be hypocalcemic. Then we need to supply the patient with very high doses of calcium tablets, and sometimes they need to be admitted multiple times for IV calcium gluconate. So that is not advisable, because there's a lot of cardiac complication out of that, and also osteoporosis as well.
Oh, I see. Okay, Dr. Chan asks, as the hyperthyroid parathyroid hormone half-life is only a few minutes, is it possible that just one serum reading may miss the hyperthyroid?
So the condition about adenoma is that it's a tumor that is producing excessive parathyroid hormone. So it's continuously producing high level. So no, it will not miss. Low normal means normal. High means high.
Okay.
Yeah.
And is it easier to do parathyroid surgery, resection, than to do thyroidectomy?
If you ask my personal opinion, a thyroidectomy surgery is easier than parathyroid surgery because because the location of the parathyroid is highly variable. So I always worry not being able to find the adenoma when I do the surgery.
Okay. Another
Yeah.
question is, when you do total thyroidectomy,
Yeah.
where do you put the parathyroid?
So usually we try our best to preserve and leave the parathyroid behind. It's all by eyes. We can identify the parathyroid gland during the thyroidectomy. But nowadays, actually we have a lot of machine that actually help us to confirm that this is actually parathyroid gland.
No, I mean as in the parathyroid sits on the thyroid gland, right?
Yes. So
So
I have to tease the parathyroid out from the thyroid gland before I remove the thyroid gland.
and then where do you place it?
No. Teasing it out and leaving it behind along with its blood supply and all that. So it will be hanging there.
Just hang on there, hang on.
Yeah. So you imagine my stress if patient total thyroidectomy because the risk of hypocalcemia because if I injure or I accidentally take out the parathyroid gland, it's actually quite high. So yeah, or it's not viable.
It will be just dangling there with that. Oh my
Yeah,
God. So there's
correct.
no like no shoulder to lean on for the
So
parathyroid.
yeah, so sad, right?
But do you still do total thyroidectomy these days?
Yes, for
Total
end stage
thyroid,
renal failure patient.
no,
Total parathyroid.
no,
You mean
total
total parathyroid where I remove all the 4 parathyroid glands, right?
total thyroidectomy.
Total thyroidectomy I still do. For
Oh,
thyroid cancer, for Graves' disease, for big goiters. So I still do total thyroidectomy.
poor
And I also do total parathyroidectomy whereby I remove all the 4 glands. So this one is special for the end-stage renal failure patients.
I see.
Yeah.
So the calcium then, okay, because they're end stage.
Somehow the nephrologist will be able to manage them. I mean, after a while, they will notice. This is one of the nephrologists that tell me that somehow the parathyroid hormone level will return to normal at some point in time, even after I do remove all of the 4 parathyroid gland. So it's very peculiar.
So if you do have to remove all parathyroid gland,
Yeah.
cannot produce parathyroid hormone anymore, then
Yeah.
the remedy is to remove their kidneys so they go into kidney failure.
Yes.
I just don't listen to me. I just will end here. Okay, bye everybody.
Yeah. Thank you for
Okay,
listening.
before we end, okay,
Yeah.
Selamat Hari Raya. Next week we have no webinar. I'm going on holiday on Saturday.
Me
I'll be
too.
back for a week. You also. And then and tomorrow is my birthday. Bye.
Happy birthday.
Thank you. See you guys. Bye everybody.
Bye-bye.
Selamat Hari Raya.
Thank you, Dr. Betty. Thank you, Dr. Wong. So
You're
sorry.
welcome. Bye-bye. Happy Raya.
Happy birthday in
Selamat Hari
advance.
Raya.